Boker Tov. It's really a pleasure for me to be here at Rambam in Haifa, and I'll echo what John said. You know, when I come to Israel, it feels like coming home. It's just by chance that I ended up in the United States. The boat for America seemed to come quicker for my parents than for Israel, so they ended up there. But my heart is always here. My heart and soul is here. So thank you. I'm going to talk a little bit about the evolution of limb lengthening techniques, and I think this is a very exciting time in the world of limb deformity correction because we have so many tools and there have been some changes. People talk about this new paradigm of lengthening. So basically, there's been an evolution of approach, but as we all appreciate, the principles don't change, and the techniques may change and the applications may change, but the principles don't change. So some of the technique evolutions have been from the external fixator, pure Ilizarov, classic Ilizarov techniques, to integrated fixation techniques, including LON, Latin, LAP. These are techniques where we use combinations of internal and external fixation to decrease the time in the external fixator. And then I think over time, many of us have gone to more and more sole internal fixation approaches, plates, static nails, and lengthening nails. And with that has come various techniques that we have applied to make sure that our techniques are accurate. And this includes fixator-assisted deformity correction and the use of blocking screws. Really things that we've learned from doing things with external fixation and then gradually applying them. So it's always nice to show an example of sort of an evolution of approach. This is a young girl that I have been taking care of. I met her when she was 8. She had a congenital leg length discrepancy. At the time, 5.5 centimeters, predicted LLD using the multiplier method to be 9.5 centimeters. And so the approach was an external fixator of the femur. This goes back quite a few years at this point. And that was stage 1 of the lengthening, and then my plan was to come back later and then do the rest of the lengthening when she was older. And by the time she became 14, now we had new technology available, and so the second lengthening, the residual 5 centimeter discrepancy, was done using a precise on the tibia, and you can see this is what the case looked like, and this is the end result. And so I've had the opportunity to have a number of patients over the years that had 2 stages of treatment, and where the first one was an external fixator, and the second one was a precise or internal lengthening nail. And you start to appreciate not only how much easier it is for you as the surgeon, but also how much easier and more pleasant it is for the patient. Another example, lengthening over nail is a technique that we embraced and used really for probably a good decade for me. And it was my workhorse treatment to lengthen over a nail using an external fixator. It decreases the time in the external fixation because at the end of the distraction, you can lock the nail and you can remove the external fixator. We saw good healing, but in our evolution with the internal lengthening nail, the LON has basically become obsolete. I mean, there are occasional indications now, but what was a technique that was really the usual, typical technique has now become obsolete. And now we will use an antegrade femoral lengthening for that same type of patient. You can see the ERC corresponding to the magnet in the nail. You get very, very nice, predictable distraction and then consolidation that follows. We actually just published this paper where we compared a cohort of patients using LON technique to precise internal lengthening. It was really a matched cohort of patients, all with antegrade femur lengthenings. And the bottom line is that although the LON technique was a very good technique, the internal lengthening had lower residual leg length discrepancy, more accurate distraction rate, shorter time to union, low rate of complications, and better knee range of motion at the end of the distraction. So, you know, it's sort of, you took a good technique and you make it even better and more simple. You know, for people, when you first start using it, you start to see things like this, which, you know, amazes you when you start doing a case like this. You know, straightforward 16-year-old with 1.5 centimeters of leg length discrepancy. And so the plan is to do a femur lengthening. But now all of a sudden, you know, you can see this is a 2-month x-ray where the patient has equal leg lengths and has really bridging callus at this point. 2 months for a 1.5 inch lengthening. So just to take you through some of the time frame, you do the surgery, you identify the magnet. At 5 weeks, he's out to length with really very, very, very minimal change in knee range of motion. A little bit, but very minimal. At 2 months, you can see the bridging and hypertrophic callus that is present. And at 3 months, it's a remodeled femur. I mean, this is a completely, you know, this might be the situation, the patient would have still been in an external fixator. We published some papers. The one on the left really illustrated how precise and accurate the precise internal lengthening nail was. We actually found that it had 96% accuracy. Well, we didn't compare it exactly to external fixation. My feeling was that it was even more, the distraction I felt was even more accurate in many cases than external fixation. And then the article on the right is a review article that we wrote and just summarized and illustrated a bunch of the different techniques. So getting back to evolution, you know, so this is a girl, 16-year-old girl with a post-traumatic growth arrest, LLD of 36 millimeters, valgus deformity. So as John was showing, you know, there's the lateral mechanical axis, and then you do your planning, and so the deformity is in the distal femur based on the joint orientation angles. This is the planning that John showed, and I've identified my cora. So this surgery was done approximately 10 years ago, and so what I did was an acute correction of the deformity with a monolateral external fixator, and then a gradual lengthening. Kind of, you know, a little bit like what you saw in that Bone Ninja, but using external fixation. And the reality is that she did very well. She healed up very nicely, and she ended up going on to do great things athletically. But I will tell you, you know, it was a tough treatment, and the knee got stiff a little bit, and it took a little while to get back to this point. Although you must admit that her quadriceps on the right side looks bigger than many of ours. But for today, you know, a few years later, we'll call it, once I've passed the precise threshold, almost identical case, right, in a young man who presented with an LLD of 20 millimeters and this similar history of a post-traumatic valgus deformity. My approach is I do my mechanical axis planning, and I intentionally make it so that the intersection is going to be where I want to do my osteotomy. And usually in the distal femur, it's 8 centimeters from the joint. You can't get closer than 8 centimeters. And then once I have that angle of deformity, I do it as a 2-stage method. So it's a little different than what John showed. Is once I decide that there's 8 degrees of mechanical axis deformity, I then get rid of mechanical axis planning and I turn into anatomic axis planning. And I take my same 8 degrees and I turn it into what I'm going to do in the distal femur. Really, the proximal axis is kind of fixed by the nail. It's a diaphyseal. And then the only thing that you really have control over is your starting point and the direction of your nail in the distal segment. And so I kind of draw that out, and you'll see multiple examples of this throughout the day and in some of the other lectures. And I use blocking screws and a fixator-assisted technique to recreate that in the operating room. The idea of using blocking screws has become very, very, very important in this technique, and understanding where to put blocking screws. And this, I like this because this was a previous fellow of mine. His name was Muthusamy. I didn't think he was that smart when he was with me during the year, but then I realized how smart he was when he came up with this reverse rule of thumbs. And I thought, you know, this is a real Ilazarov, because sometimes it gets confusing. Where do you put the blocking screws? Well, Ilazarov surgeons know the rule of thumbs, and it's very easy. Your brain is very easy to show you the rule of thumbs. Well, it turns out that blocking screws are always the opposite of the thumb and the finger. It really works out that way. If you go through every single case, now you don't necessarily have to use 4 blocking screws on each case, and you can use your judgment about when, how many are needed. Sometimes it's 1, sometimes it's 2, and sometimes it's none. But the location of the blocking screws in terms of near the osteotomy and away from the osteotomy always follows the reverse rule of thumbs. So as you start to look at some of these cases of location of the blocking screw, I encourage you to sort of see if it matches up. But in this case, we're correcting valgus deformity. So this is the way that I approached it. The first thing I do is I make my drill holes for the osteotomy, and then I put my blocking screws. My blocking screws are put in very early in the case. I like to do them early. And I also pay a lot of attention to the direction of the nail in the distal segment. And you can see I've got my external fixator pin. I only use a 2-pin external fixator. In this case, the blocking screws are in the concavity of the deformity adjacent to the osteotomy. And that's kind of the most typical place that we will use the blocking screws. This is the setup that I use. I use a triangle to provide support. I do the osteotomy, correct the deformity acutely, and then I do the reaming in the correct position, and then you can see the nail being inserted. We leave the operating room looking something like that, and then as we distract, you can see the final correction. You can see the bone formation is very, very nice, very predictable. And with retrograde nails, your nails, you have to be attentive to the fact that you're usually not going to cross the proximal bow. So usually the nails are a little bit shorter. They're not these totally long nails. So you have to take that into account when you're doing your planning. Progressing in the theme of evolution, this is an example of a man who had a growth arrest in his humerus, and you can see shortening of his humerus related to the growth arrest. And so many years ago, I treated this with a monolateral external fixator, a very nice technique in terms of great bone formation. And we actually published a paper in Core showing our results of using monolateral external fixators and how wonderful it was for improving DASH scores and overall outcome. Happy patient. But then, a few years later, we have the precise nail, and although they do not have a humerus nail, so this is an off-label application of the nail, and if this were an official precise course, they would get angry at me for showing this. But since this is not an official precise course, we can show whatever we want. But this is, you can use a trochanteric nail in a way that's very similar. So you can use trochanteric or even tibia, but trochanteric nail is pretty much very similar. So we do the osteotomy, acute correction of deformity, identify the magnet, and you can see this is the distraction that has occurred, and this is as the consolidation progresses. Now, the range of motion and the function, this is soon after the end of distraction, is better. There's less stiffness of the adjacent joints. You'll see that as a common theme, and the healing is very, very nice. And in this case, actually, because of the varus deformity of the proximal humerus, we actually didn't even have to touch the rotator cuff because the entry point was actually lateral to the rotator cuff. The hexapod frame is something that I think many of us have embraced and have used with a lot of passion, and there's an indication for it. I mean, there are cases where you cannot do lengthening with a nail. So, I mean, here's an example of a woman with a very large oblique plane deformity and shortening from fibrous dysplasia. You can see the coronal plane deformity, the sagittal plane deformity, and I used a single osteotomy approach and gradual lengthening with this type of hexapod frame. This is the outcome at the end. with good deformity correction, and this is the way it healed up. Even though the bone has a little bit of a hump, overall, this seemed like the best solution. It was such a big deformity, it wasn't really room to make 2 osteotomies. But this is what you can do with a hexapod frame, with a circular frame. And you can't do a case like that with an internal lengthening nail. But there are other indications where we will use the internal lengthening nail in ways that we wouldn't have done before. So for example, here you have a young woman who had neonatal hip sepsis with an unstable hip and a leg length discrepancy, painful unstable hip. You do your analysis of her LLD, you can see she's 1 3/4 inches short. Now you're going to get a certain amount of length from your hip replacement, but you're not going to get it all back. And really, when it comes to doing hip replacements, the hip replacement surgeons should do the best hip replacement you can do, and you shouldn't use hip replacement to try to over-lengthen somebody. You kind of put in the best hip replacement, and there are complexities with that. But the point of this is that you can predict that there may be residual LLD after the hip replacement. Sometimes here it's as expected. In many cases, there are cases where patients don't expect to have leg length discrepancy. But the bottom line is we've used a retrograde approach to these cases where you can go right below the hip replacement. Maybe in the past you would have been uncomfortable applying an external fixator, but here you could do a retrograde technique with lengthening, and you can see the consolidation. The bone healed very, very nicely. We embraced Latin, lengthening and nailing, as a technique for correction of deformity and lengthening of the tibia. And it's something I used really for many, many years. I really was very passionate about this technique. We would apply the external fixation a little bit more peripherally so that there wasn't contact with the nail. And what that allowed us to do was then put in a nail in a staged fashion, get the external fixators off more quickly. We had very, very good results with that. After the IM nailing, you can see there's no contact between the infix and exfix, allowing the frame to be removed. So, this would have been a typical case, 4 centimeters LLD in an adult patient with some valgus deformity. You do your deformity planning, you do your osteotomy, gradual lengthening and correction of the deformity, and at the end of the distraction, maybe 6-8 weeks later, you get it straight, and you insert a locked nail, and then you take the fixator off. Great technique, loved it. Now, in today's world, the same patient, I would do a little differently, right? So here's an example of a 25-year-old with a similar kind of problem, malunion with 25 millimeters of shortening and valgus deformity. I do my analysis, and I do my planning. There's my cora, and I have to figure out my osteotomy distance, which was 180 millimeters from the joint. We're going to get into figuring out the length of the nail, so I don't want to get into all that for right now, but we figured out the length of the nail. I template and draw my nail as it's going to be in the proximal segment. And the key thing here to really to accomplish the deformity correction is to use a blocking screw, because the width of the canal is greater than the width of the nail. So you're really not going to get a good deformity correction or a complete deformity correction without the blocking screw. And even if you leave the operating room and it looks pretty corrected, as you lengthen, it's going to go into more valgus. So the blocking screw is really key, and we'll keep coming back to that over and over again. And that's what I did here. I used the blocking screw. It allows correction of the deformity. You can see the lengthening, the progression of healing, and this is the outcome with a nice straight leg. We've all seen patients with infected pilon fractures where we've done ankle fusions and they're missing a segment of bone. So the approach that we will use is ankle arthrodesis and then staged or simultaneous proximal tibia lengthening. And so we would make these bifocal type of approach. We were lengthening up top, and then we translated that into Latin. So we would use the lengthening and nailing approach. And so you can see here's at the end of the distraction, and the ankle fusion is healing, and we set it up for Latin, so at the end we put a nail in so we can take the fixator off a little bit more quickly. And we had very good success with this technique. We published on complex ankle fusions using these bifocal types of approaches. This is the outcome. But again, in today's world, I'll show you another case, similar but different, right? And here's a woman who had a trauma many years earlier, and one of my partners put in this total talus replacement 13 years earlier. She actually got a good number, she got a decade of good pain relief, but you can see the erosions of the tibia and of the calcaneus. It became painful. So ultimately, this needed to be converted. The plan was to remove this implant, but you can see that she's got a total bone loss of 50 millimeters. And so the planning that went into this included a tibiocalcaneal arthrodesis. I chose to do that with an external fixator. And then at the same time, I did my lengthening proximally with a precise nail so that the frame was less difficult and easier for the patient. Small little frame on the bottom. And you can see as the ankle fusion is healing, the tibia lengthening is healing, and this is what it looks like in the fixator. Even though the patient is in the fixator, it's a much smaller fixator, and the distraction with the nail is actually a lot easier than the distraction with the big frame. And this is what it looks like when it's all healed at both sites. And she had an excellent clinical and functional result despite a tibiocalcaneal arthrodesis. Traumatic bone defects, we would do classic Elizarov technique to do bone transport. Everybody in this room has experience doing these kinds of techniques. They're great techniques. They work beautifully. You can transport the segment down. You can use a classic Elizarov technique, or you can use a hexapod frame, and you can get healing at both sites. And this is what it looks like in the fixator. You accomplish equal leg lengths, and at the end, you have a situation that looks like this with an excellent clinical result. But, you know, the patient has to wear the fixator for almost approximately 1 year. So the techniques that have evolved have become these hybrid techniques. So in many cases, we'll approach a case like this with a large infected bone defect, 17-centimeter defect, with a draining sinus, big segment of necrotic bone with excision of the segment, and then we put an antibiotic-coated nail in as a stage 1, and then stage 2, we will do bone transport over a nail, right? Using a fixator, using pulleys, but what this allows us to do is as soon as we get the docking, right, you can see that the pulleys are pulling the nail down. This is a modification of the Weber technique, doing it over a nail, and you can see the segment is being pulled down, gradually being pulled down. You can see the regenerate is progressing, and then as you get down to the docking, once you get to the docking, you can then take the fixator off. And so this patient was in and out of the fixator within 6 months. And we analyzed this in a paper of comparing integrated fixation compared to classic technique for post-traumatic bone defects. And basically we showed it was, you know, you accomplished the same thing, but you had some of the fewer complications and that you had much less time in the frame. So, and the follow-up to that is that while we don't have it available right now, probably within the next 1 to 2 years, we will have an internal lengthening, an internal transport nail that is available, and then that will make even the transport over a nail become an old, obsolete technique. So I'm going to close by quoting this poet who said that healing is not science, but the intuitive art of wooing nature, and I think we take advantage of that. We try to create the optimal environment, both biological and mechanical, and enable the body to heal and to regenerate. Thank you for your attention.